We are going to have a discussion by Professor Henrik Groop, who is a professor in the Department of Diabetes at Monash University in Australia. He is a professor of internal medicine and chief physician of the Abdominal Center Nephrology at the University of Helsinki. And really we are going to talk about a subject which is in the center of the core of a lot of discussion, which is the metabolic cardiorenal continuum and the association between these three, the metabolic event, the renal complication and the cardiac complication, and how much they are interrelated and one lead to the other and one is associated to the other, and how the treatment can change according to fixation of this continuum. Professor Henrik, you are definitely welcome.
Thank you very much, and thank you for having me at this...
Your voice is muted. We don't hear you.
You should, can you hear me now?
Yes, now.
Okay, perfect. Okay, thank you for that introduction and thank you for having me on board this important meeting. And I just was listening to Antonio's great talk. And we can come back a little bit to the ketones also when it comes to the kidneys. But my task here is to talk about the important conversation between the heart and the kidney. But before I do that, these are my disclosures. Cardiorenal metabolic systems. This is a new way of looking at how the heart, the kidneys, and also the pancreas, how these systems work together. So this slide shows that regulation of energy metabolism by the liver, the pancreas, and fat is essential for healthy functional organs, especially the heart and the kidneys. But the heart is the most metabolically demanding organ, susceptible to changes in volume and metabolism. And then the kidneys, they play a key role in the glucose and volume homeostasis and blood pressure regulation. Now, let me remind you about one thing. The cell type in the body with the highest number of mitochondria, that is the heart, the cardiac cells. But the second highest number of mitochondria in any cell in the body is in the proximal tubule. And the proximal tubule is extremely important because the crosstalk between the kidneys and the heart is very much focused on what happens in the proximal tubule. And I will come back to that later on. So this is a slightly busy slide and tells us how this a disease in the heart can affect the kidneys and vice versa. I think it's important to keep in mind that if you have a problem in the heart, watch out for problems in the kidneys. If you have a problem in the kidneys, watch out for problems in the heart. And you can see here, if you lose kidney function, what will happen after losing kidney function is basically you will have an activation of the renin-angiotensin-aldosterone system. You will have sodium and water retention. You will also have a sympathetic drive. These will have an impact on the heart. And also you can see that when you have cardiac dysfunction, that will cause a lot of hemodynamic changes, that will affect the kidneys, etc., etc. And here in the middle, we have the sympathetic drive. And here we have the natriuresis. So I think it's quite clear that kidneys and the heart, they go together, and we cannot look at one organ just as such and forget the other one, because they work together. And also keep in mind that 25% of the cardiac output reaches the kidneys. So the kidneys, in fact, have to protect themselves against too much oxygen. And you know that the kidneys are extremely vulnerable to hypoxia. In a situation where we have obesity, hypertension, and diabetes, what is typical for all these is that you have hyperfiltration, you have an increased renal blood flow, and anytime you have hyperfiltration in the kidneys, you will push the sodium handling in the proximal tubule. And that will deplete the oxygen depots in the kidneys, and you will actually cause kidney hypoxia. And we can talk more about that later on, but the kidneys and the heart, they go together. And this slide also shows that when we have risk factors that I was already alluding to, you can see that these are risk factors not only for atherosclerosis, but also for the kidney problems. So you start with endothelial dysfunction, atherosclerosis, microalbuminuria, macroalbuminuria, coronary artery disease, myocardial infarction, stroke, chronic kidney disease, heart failure, end-stage renal disease, and cardiovascular death. So what this slide shows is that if you have a problem in one of the organs, watch out for the problems in the others. So let me actually show you what comes with the kidney disease. So if a patient will have type 2 diabetes and chronic kidney disease, what will happen? But the first question is, how common is chronic kidney disease in patients with type 2 diabetes? And if you go out and screen for chronic kidney disease in patients with type 2 diabetes by looking for albuminuria or a reduced eGFR below 60, or both. That was done in the demand study on a global scale, and you can see 56% had either reduced eGFR below 60 or albuminuria or both. So more than every second patient had signs of diabetic kidney disease. If you go to Asia, it's 68%. I know that in your part of the world, this is also very, very common. So chronic kidney disease is a common complication in patients with type 2 diabetes. And when you have that, you can expect a manifold increased risk of premature mortality, but you can also, importantly, at the left-hand side, you can see that when you lose kidney function, you will also see an increased risk of heart failure and ending up in hospital because of heart failure. The same is true for progressive albuminuria. And these data are based on the Swedish database of more than 250,000 patients with type 2 diabetes. So kidney disease comes with premature mortality, a risk of premature mortality, also a risk of cardiovascular events, but as shown in this slide, very importantly, also heart failure. So why do we see so much cardiac problems in those with kidney disease? It's no doubt, because if you have diabetic kidney disease, those patients will have hypertension, oxidative stress, they will be insulin resistant. You will see arterial calcification, chronic inflammation, as Antonio Ceriello was talking about. You will have left ventricular hypertrophy, endothelial dysfunction, activation, renin-angiotensin-aldosterone system, activation of sympathetic nervous system, anemia. All these factors come with diabetic kidney disease, and they're all risk factors for heart disease. So no doubt, the patients with type 2 diabetes and kidney disease, they are at high risk of problems in the heart. And let me show you this important slide. And this is probably one of the most important slides in this talk. If you have a 60-year-old patient with type 2 diabetes, you can expect, just by having diabetes, 6 years shorter life expectancy. If that patient has suffered a myocardial infarction or a stroke, you can expect 12 years shorter life expectancy. But if you have signs of early diabetic kidney disease, that means albuminuria or reduced eGFR below 60 or both, you can expect 16 years shorter life expectancy. So the consequences are grim. And it also means that we need to take action. So let me now go through the data we have from recent cardiovascular trials, dedicated renal and heart failure trials, how we can modulate the crosstalk between the heart and the kidneys. So first, just one slide on the cardiovascular outcome trial effects on the heart. And this slide you have seen many, many times. The first SGLT2 inhibitor trial out was the EMPERIC outcome trial, showed a 14% reduction in the MACE and astonishingly large effect on the risk of cardiovascular death and also hospitalization for heart failure. The CANVAS program showed a similar effect on the primary outcome, the 3-point MACE, not on cardiovascular death, but also the hospitalization for heart failure. DECLARE-TIMI showed also an effect on the heart failure, but not on these two. On the other hand, the DECLARE-TIMI also included a lot of patients not with established cardiovascular disease, but with risk factors. The last one out, VERTIS-CV, also strong effect on the hospitalization for heart failure. So This is the effect we have seen many times now with SGLT2s on effects on the heart. But what about then in these cardiovascular trials? What did we learn from them in terms of the kidneys? Now, the kidney outcomes are secondary outcomes, so we cannot draw far-fetched conclusions about it. But the first out was the EMPA-REG again. EMPA-REG outcome that showed a 39% risk reduction in kidney outcomes with empagliflozin. And this basically means that you add on all the kidney outcomes, which means doubling of serum creatinine, ending up on dialysis, etc., etc. Now, if you then look at what happened in the EMPA-REG outcome trial, you can see in the kidneys, you saw a drop in the initial drop in eGFR, and after which you saw a preservation of the kidney function. Absolutely fantastic news. These data were then replicated in the CANVAS program. Also, wonderful effect on a composite kidney endpoint. Now they did not use a doubling or serum creatinine, but they used this sustained 40% reduction in eGFR, need for renal replacement therapy, or death from renal causes. Very similar effect, 40%. It was 39% in EMPA-REG. And again, initial drop in eGFR, then preservation of the kidney function. The CLEAR-TIMI, very similar data. And when you then look at all these trials together, so the EMPA-REG outcome, CANVAS program, the CLEAR-TIMI. Now, these were not dedicated renal trials, but they were cardiovascular outcome trials that had kidney endpoints as secondary outcomes. And you can see that they were, in those with established cardiovascular disease, all of them left of the unity line, and astonishingly large effect on the hazard ratio of 0.56. But what is important here is that if you look at those with multiple risk factors, when it comes to the kidney outcomes, you can also see a reduction in the risk. This is different from what we saw on the cardiac outcomes. So what about then the last out, that was the VERTIS? Now, everybody said that the effects in the VERTIS CV were not significant. I'm showing this deliberately, this slide where we are looking at a sustained 40% decrease. Then you can see down by 34%. So similar effect as all the others. Why do I say this? Because actually the design of the VERTIS CV in terms of the kidneys was a little bit mistake. They did not require a sustained doubling or serum creatinine or a sustained decrease in the eGFR, one single sample, and that doesn't work. That's the reason. But when you do it in a proper way, look at the sustain, you actually have the similar effect. So all SGLT2 inhibitors seem to be renal protective when you look at the data in cardiovascular outcome trials. However, these are not dedicated renal trials. So we need to look into kidney trials and see what we can we actually prove the renal protective effects. So the first one was the CREDENCE trial. That was in patients with type 2 diabetes and established kidney disease. And this is the primary endpoint, which was a combined kidney and cardiovascular death. So at that time, when this CREDENCE trial was designed, was before the other big cardiovascular trials. And the authors of this paper and those that designed this study are very proud of that, because they were out very early. But they did not dare to use only a renal endpoint. So they had to do a combination of renal and cardiac endpoint. But the good news, 30% reduction in this primary endpoint. But look at what happens when you get rid of the cardiovascular death. You just look at the kidney endpoint, which is again doubling on serum creatinine, very hard endpoint. Keep in mind that doubling on serum creatinine means a 57% reduction in eGFR, not 50%, 57%, so it's a hard endpoint. Now you can see that the hazard ratio is even lower, 0.66. So the effects on the kidneys are absolutely astonishingly good. Now, in the CREDENCE, if you project the effects, and you can see here that the average CREDENCE patient was 63 years old and had an eGFR at baseline of 56. And this is the placebo group. The placebo group that were exposed to placebo, they lost 4.6 ml per minute per year. So it would take about 10 years to reach an eGFR below 10, which basically means dialysis. In the patients exposed to canagliflozin, they lost a lot less, so 1.85 ml per minute. So it basically would take up to 25 years to reach that target. So this means that you can basically gain 15 years of longer life by exposing the patients to an SGLT2 inhibitor. You remember what I told you? The early signs of diabetic kidney disease confers to loss of about 16 years of life. So this is not an extrapolation. This is not studied. So we don't know if this is true, but let's say the potential is there. Now, if there's another trial, dedicated renal trial, DAPA-CKD. Now they also use the combined endpoint, not the doubling of serum creatinine, but a sustained more than 50% eGFR decline. And again, very similar data point, hazard ratio 0.61. So now we have two trials showing that, yes, by exposing patients to either canagliflozin incretins or dapagliflozin, DAPA-CKD, we can show renal protection. And the DAPA-CKD did not only contain patients with type 2 diabetes, as in the cretins, but also patients without type 2 diabetes. And you can see that the effect on the primary composite outcome was exactly the same, whether the patients had or had not diabetes. And if you then look at the single kidney outcome, so and get rid of the cardiovascular death, again, you can see an even stronger effect. So these two trials proved that, yes, SGLT2 inhibitors are renal protective. Now, what have we then learned from dedicated heart failure trials? And now the question is, what have we learned in terms of the kidneys? The first heart failure trial was the DAPA-HF. And the primary composite outcome was a worsening of heart failure or a cardiovascular death. And you can see hazard ratio 0.74. And the DAPA-HF consisted also of patients without diabetes, so both diabetes and non-diabetes. And you can see wonderful effect, reducing the risk of worsening of heart failure and a cardiovascular death. Now, EMPA-REDUCED was the second out, and you can see a similar endpoint and has a ratio of 0.75. So very similar data. And now it means also in dedicated heart failure trials, the effects we saw in the cardiovascular outcome trials in the first place on heart failure seems to hold true. And that means that they are also protective when it comes to progression of the heart failure. Now, let me show you one important aspect, which was studied in the EMPA-REDUCED. This is a busy slide, but it tells us that when you look at different trials throughout the recent years, trials with intensive blood pressure control, those with RAS blockers, intensive glucose control, allopurinol, sulodexide, simvastatin, empagliflozin. And they have looked at the treatment effect on the GFR slope. And then they look at the effect on the hazard ratio. And then you can even, based on these trials, you can expect, for instance, if you have improvement about 1 ml per minute per year in the eGFR, you can expect 0.65 of the hazard ratio. So let's see what happened in the EMPA-REDUCED. Actually, what was seen, this is the steep decline in those exposed to placebo, and these are the ones exposed to empagliflozin. And you can see, in fact, they gain more. In 16 months, they gained about 1.73 ml per minute per year. And that was translated into a hazard ratio of 0.50. I told you that 1 ml would already have given a hazard ratio of 0.65. But since it was even stronger, you could even expect a stronger effect on hazard ratio. So this shows us that, yes, empagliflozin, as also was shown with dapagliflozin, they can also show renal protection in patients that have heart failure and actually are treated because of the heart failure with the same drugs that also have effects on the kidneys. And I will just show you also the data from the DAPA-HF on the kidneys, and it actually comes here on the bottom, so the composite kidney endpoint in EMPEROR reduced, 0.52, DAPA-HF 0.71, both on the left of the unity line. So this means that basically, if we use a medication that works on the kidneys, you block the reabsorption of sodium in the proximal tubule. And you remember what I told you, that the heart cells and also the proximal tubule cells, these are the cells in the body with the highest number of mitochondria. And that must mean something. And when you have diabetes, when you have hypertension, when you have obesity, you will have an increased renal blood flow. You will push the filtration rate, you will have hyperfiltration, and then you push the reabsorption of sodium in the proximal tubule. And you will actually deplete the oxygen levels in the kidneys. And actually, the end result is hypoxia. And I can tell you that in experimental animal models, if you induce diabetes, within 3 days, the kidneys are hypoxic. If you give a drug that causes kidney hypoxia without diabetes, without reactive oxidative species, you just cause kidney hypoxia. The phenotype is proteinuria, inflammation, cell damage. So kidney hypoxia is something that is extremely important when it comes to the kidneys. And of course, if you have kidney hypoxia, you will have activation of renal angiotensin system, sympathetic drive, and these and sodium and water. You will have actually you will gain water and sodium, and that all these will have an effect on the heart. So let me tell you that when you then, with an SGLT2 inhibitor that blocks this sodium reabsorption, we have this wonderful effect, not only on the kidneys, but also on the heart. So that, of course, tells us that, yes, these systems work together and they are interrelated. And also, I think this is important to keep in mind. If you have an acute, or why not a chronic dysfunction in the heart or the kidneys or the metabolic system, that may induce dysfunction in the other. And diseases of these systems share many of the same risk factors. Diabetes confers increased risk of cardiovascular disease, heart failure, and shortened life expectancy. Kidney disease is common in type 2 diabetes with grim consequences. So increased risk of dying early, increased risk of cardiovascular events, increased risk of hospitalization for heart failure, and of course, also risk of ending up on dialysis. Multifactorial treatment that we have been using throughout the years works, but there is still a large unmet need. So the cardiovascular outcome trials with SGLT2 inhibitors, they have shown cardioprotection. So when we have a look at the primary outcomes, and renal protection is secondary outcomes on top of the multifactorial standard of care. But I think it's also important here to keep in mind that dedicated kidney and also heart failure outcome trials have proven the renal protective effect of these medications shown in Credence, DAPA-CKD, DAPA-HF, and EMPEROR reduced. And just to finalize, these new medications, the SGLT2 inhibitors, we have learned a lot how the kidneys works, how we can affect the heart, and also we have learned how the heart and the kidneys work together. And I think now it's time for endocrinologists, cardiologists, nephrologists to work together, because we have exactly the similar and the same problems that we are facing. That said, my dear colleagues, thank you for your attention.
Thank you very much, Professor Henrik Groop. It was really a very interesting and futurist way of treatment. I remember that very few years ago, very few years ago when they started to talk about the heart and the kidney, and in the ADA guidelines it had been put as an isolated item. At that time everybody was saying we have only 20 to 25% of type 2 diabetic having kidney or renal problem. With time, with these few years, we started to hear more and more, because it's no more atherosclerotic cardiovascular disease, it's patient with high risk. It's no more people with frank kidney disease, it's people having more than 50% of type 2 diabetes actually now may have some kidney affection, whether hypertension, proteinuria, or so on. So the spectrum of this kind of treatment is really very much increasing, and we do see the benefit out of it. We do see in the elegant dealing of patients with heart failure. There is an interesting point: how much low can we go into estimated GFR to use this group of drug? It had been on 60, and then 45, and then now 30, and even 20 in heart failure. It's going down, in spite of the fact that for diabetes control we are talking about a 45, but for other renal protection or cardiac protection we can go definitely lower.
Can I respond to that?
Yeah.
This is have been from the beginning one of the problems to get people to use SGLT2 inhibitors. And you know that if you look at the global scale, the uptake of SGLT2 inhibitors is about 10%. It's even below 10%. So this is a real problem, because people are very often asking, can I use these medications? And the labels in many countries still say that you should not start this medication if the eGFR is below 60. Some countries you can go down to 45. In some countries, at least Canada and Philippines, I know that they can go down to 30. Why is this so totally, let's say, the mess? And this mess is due to the fact that SGLT2 inhibitors, when they came on the market, they were by definition glucose lowering medications. So, of course, you prescribe these medications to reduce the A1C, because you got rid of glucose in the urine. Now, that glucose excreting effect fades away when you lose kidney function. So if you have an eGFR of 90, 60, or 30, the glucose lowering effect will fade away. And it was quite clear that the companies could not market glucose lowering medications in a situation where the glucose lowering effect was fading away. What we learned from the cardiovascular outcome trials was that the effects on blood pressure, the body weight, and also this renal and cardioprotection was there, although the patient lost the glucose lowering effect. So we have learned a lot, but still the guidelines in many countries, the labels in many countries, they are not taking this into account. And I do hope that soon FDA and EMA will come out with new guidelines that we can use eGFR down to, I would say today, down to 20. And the reason why I'm saying that, all the cardiovascular trials, not the DECLARE team, but all the others, patients were involved down to an eGFR of 30. Also in the Credence, down to 30. In the DAPA CKD, also down to 30. But in the heart failure trials, down to 20. And have we seen side effects? No, we haven't seen more of acute kidney injury. It's the opposite. And I was responsible for a trial where we had a eGFR down to 15 with sotagliflozin, and we did not see any problems whatsoever. So this is let's say a problem, historical problem, because of these were glucose low medications, but now it's switched to renal protection, cardioprotection.
Thank you very much for this enlightening answer. This is the evolution of science, and this is the beauty of it, that within very short time we are going step after each other. I don't know if there is in the background, in the ground, any question?